disease and premature death is the holy grail of public health. And since at least the time of Hippocrates in the 5th century, doctors have sought to prevent diseases as well as to offer treatments and cures. The history of medicine is marked by major successes in preventive medicine, and these include the prevention of scurvy by the dietary provision of vitamin C, beginning with the James Lind Treatise in 1753. The development of smallpox vaccination by Edward Jenner in 1796. That was a bit of a jump. The prevention of puerperal fever by hand washing by Ignaz Semmelweis in 1847. The capping of the Broad Street pump by John Snow in 1854 to end a cholera epidemic. And the discovery of the link between smoking and lung cancer by Richard Doll and his team in 1950. And the development of vaccination against polio in the 1950s. Each of these and many similar examples have prevented hundreds of premature deaths and incalculable human misery. Indeed, the consideration of preventive advice remains an essential component of every medical encounter. Long ago, in 1979, Stott and Davis listed 4 possible components of each consultation in primary care. And the last of these was the opportunist health promotion, advice made more effective by being directly linked to the content of the preceding consultation. Advice to stop smoking is proportionately much more powerful when it is linked to an episode of acute bronchitis or a first presentation of angina. But throughout human history, unscrupulous people have sought to make money out of human illness. And one contemporary manifestation of this is the global screening industry, which sets out to identify an ever greater proportion of the population as being at risk of premature death or disabling illness, and then to sell a preventive intervention. More than a decade ago, David Sackett, the epidemiologist and pioneer of evidence-based medicine, warned us in this way. The two disciplines of curative and preventive medicine are absolutely and fundamentally different in their obligations and implied promises to the individuals whose lives they modify. And Sackett went on, preventive medicine displays all 3 elements of arrogance. First, it is aggressively assertive, pursuing symptomless individuals and telling them what they must do to remain healthy. Second, preventive medicine is presumptuous, confident that the interventions it espouses will, on average, do more good than harm to those who accept and adhere to them. Finally, preventive medicine is overbearing, attacking those who question the value of its recommendations. When someone feels unwell and seeks relief of symptoms, the doctor has a clear responsibility to do his or her best, but cannot guarantee success. In primary preventive care, the doctor seeks out the patient rather than vice versa, and with an implicit promise of benefit, offers someone who is at present in good health an intervention which it is expected to make their life better in the future. Unfortunately, all such interventions oblige the recipient to consider a range of possible threats to their health and are almost always associated with a degree of heightened anxiety and fear. For some people, this fear can become overwhelming and debilitating in itself. And in Dennis Pereira Gray's memorable image, preventive interventions can stain the clear water of health with the ink of fear, and once stained, the water can never be made clear again. Fear cannot be taken back. The diagnosis of risk is not something to be undertaken lightly or unthinkingly. And unfortunately, the almost universal fear of death and the desire for longer and healthier lives is reflected in huge enthusiasm for preventive medicine on the part of government, the media, the public, and some doctors. This enthusiasm is assiduously cultivated by the pharmaceutical and health technology industries and is driving the identification of more and more risk factors and more possible interventions for each of these. Cancer prevention strategies seem to be assuming more and more of the features of a moral crusade. In the 1950s, educational materials promoting breast self-examination implied that an advanced breast cancer is a self-inflicted disease. This is a much more recent example. If you haven't had a mammogram, you need more than your breasts examined. Clearly the A responsible and rational citizen is expected to actively seek out and eliminate all possible risks to their future health and to consume medical technologies in order to achieve this aim. Yet, for every 2,000 women invited for screening throughout 10 years, one will have her life prolonged. In addition, 10 healthy women who would not have been diagnosed if there had not been screening will be diagnosed as breast cancer patients, and this is not mine, and it's making funny noises, thank you. 10 healthy women who would not have been diagnosed if there had not been screening will be diagnosed as breast cancer patients and will be treated unnecessarily. Furthermore, more than 200 women will experience important psychological distress for many months because of false positive findings. This is from the Cochrane collaboration. Screening always causes harm because overdiagnosis and false positives are inevitable. And then only last week, this article appeared in my morning paper. Breast cancer screening shown not to